Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Paul Kim from California Orthopedics and Spine, California, United States. After his medical education at the Wayne State University School of Medicine in Detroit, Michigan, Dr. Kim pursued his orthopedic residency at the University of Washington in Seattle. Subsequently, he did a fellowship in foot and ankle surgery at the Hospital for Special Surgery in New York, United States. He's won several awards, including the American Orthopedic Foot and Ankle Society Resident Scholar Award, the Wayne State University Award, and several more. If you've noticed, Dr. Kim has delivered a lecture on a channel and it's already reached a huge audience. And today it's my great honor to bring back Dr. Paul Kim for this wonderful live program. Over to you, Paul.
Well, thank you, Dr. Gopalan. I really do appreciate this opportunity to share some of my experiences. And today we'll be discussing Achilles treatment and a little bit different approach to treating Achilles, not the traditional approach. So let's talk first about Achilles pathology. So, the two things I'm going to be focusing on today are Achilles rupture and Achilles tendinopathy. Now, Achilles ruptures tend to occur in the watershed area, which is usually about 2 to 6 centimeters proximal to its insertion. Often it occurs in people that are involved in sports such as basketball, soccer, and running. As you can see in that picture on the right, there is a distinct watershed area. Also, as you can see, the midline is also a watershed area. So for my Achilles surgeries, I tend to air my incision a little bit more medial, which is the more vascular area. Because as we all know, wound complications are one of the biggest detriments of treating Achilles ruptures surgically. And this is a picture of my patient who I wanted to include, and I'll show a picture of him walking after his Achilles rupture surgical repair. And that's a picture of his ankle 6 weeks out from his surgery. The other topic we'll be focusing on today is Achilles tendinopathy. Now, tendinopathy is the degeneration of the Achilles tendon from repetitive microtrauma or even micro tears, and the Achilles native tissue is eventually replaced with type 3 collagen tissue. This often results in thickened, calcified tissue, and can also be associated with a haggling deformity. So if you look at the evolution of Achilles treatment, it has recently evolved. So the tried and true. So if you have an Achilles rupture that's going to be treated surgically, it's typically an open end-to-end repair using Krakow sutures, knottable sutures of some sort, like fiber wire. When you talk about tendinopathy, it's usually the large French door incision where you go midline, you detach the Achilles, debride the calcaneus, or you can go from the lateral side with another large incision, debride the calcaneus. The modified techniques have taken a step further. Now for ruptures, I use the percutaneous Achilles repair system from Arthrex. It's also the mid-substance repair kit, and I'll go over what that means. And for tendinopathy, I've been implementing a newer technique using the minimally invasive surgical burr as well as speed bridge repair. And biologics have been around, but biologics are really starting to take off. So for any soft tissue work such as Achilles in my practice, I do incorporate PRP, BMAC, and amnion. PRP being platelet-rich plasma, BMAC being bone marrow aspirate concentrate, which I actually harvest from the ipsilateral iliac crest, and amnion, which is dry harvested umbilical cord tissue, which is sterilized. So let's talk about this treatment. Now, both conditions, I want to emphasize, can be treated non-surgically. Yes, Achilles ruptures can be treated non-surgically. If you have a ruptured Achilles, it's best to put them in an equine splint and start functional rehab once ultrasound confirms there is some level of healing. Now, in my practice, when I do decide to treat an Achilles rupture non-surgically, I do advise the patients to have a PRP injection, and that is injected directly under ultrasound. For tendinopathy, you can always do physical therapy, eccentric stretching, heel lifts, modified activities, shoes, etc. This is a picture of me. This isn't Achilles, but this is a picture of me injecting BMAC and a PRP combo onto a allograft chip for a first TMT arthrodesis. And so I just wanted to show that it's not just for soft tissue, but you can also use it for other applications in orthopedic surgery. So now I wanted to focus more on the surgical part of Achilles treatment. So the first, we'll talk about Achilles rupture and using the Arthrex PAR system with mid-substance repair and amnion and BMAC and PRP. The second, we'll talk about the Achilles tendinosis with Haglund, which you can treat with a MIS resection, arthroscopic assistance, BMAC PRP, and arthritic speed bridge. So talking about Achilles rupture, I like the Achilles PAR system. Why? As you can see in this video, it's a smaller incision. With this jig, you are able to extend and incorporate a more proximal stump of the Achilles and not having to make that large incision. Now, in the guide, they usually tell you to make a horizontal incision. I like a vertical, just in case you need to extend that incision. Also, one of the pearls is when you're putting this jig in, before you start incorporating these percutaneous sutures, make sure that the jig is externally rotated about 10 degrees to ensure that you don't get the sural nerve, and ensure that you are definitely within the peritoneum. Again, this will also ensure that you're not going to go and capture the sural nerve. So why do I like the mid-substance kit? So what is the mid-substance kit? Well, the mid-substance kit is basically using the PARS device, passing the sutures through the distal stump and anchoring it into the calcaneus with bones, biotendinosis screws. So why is that important? Well, because you have no chance of knot failure. There's little chance of creep, and the vertical anchor placement, even though the anchor might pull out a little bit, doesn't bother people. And also, the biggest thing of this is it's a quicker functional rehab. And what does quicker functional rehab mean? Well, the first 2 weeks, I keep my patients non-weight bearing, but then I actually start them walking at 2 weeks, and they have, the equinus wedges, and they'll have active dorsiflexion neutral and passive plantar flexion. But each 1 to 2 weeks, depending on their symptoms, they'll start removing a wedge. And PT starts about a month after. So this is a picture of that gentleman I had earlier. He was only 6 weeks out from a repair of his Achilles rupture using the Arthrex mid-substance, amnion, BMAC, and PRP. Now, this is a very unique story. So as you can see with his Hawaiian shirt, he was actually vacationing in Hawaii. And I think within a week of his vacation, he ruptured his Achilles. And he told me, he's like, there's no way I'm going to come back to the United States to have my Achilles repaired. So I'm going to wait another good 3 weeks before. So he was a delayed presentation. He had about a good 4 centimeter gap where his Achilles had ruptured. And so it was a delayed presentation, but yet he had a full recovery. So I would say most patients are able to return to most, if not all, activities by 3 months. And as you can see in this video, you can't even really tell that he has a limp. He has a slight limp, but overall, he has a good normal stride gait. As you see his calves engaged, he has good architecture of his calf. And so this is an amazing recovery just at 6 weeks. And he's not the most young person. I mean, he's a typical older adult male that lives in Marin, California. So let's go over the technique a little bit step by step. So obviously you have to do the prone position. I do elevate the operative extremity, so you can use fluoroscopy for your anchor placement into the superior aspect of calcaneus. The PAR system, you got to make sure that you're within the peritoneum and you have a little bit of external rotation to avoid injury to the sural nerve. And on the step 3 is like, as you can see me marking out, that's the superior aspect of the calcaneus. And once I make that incision, I'll pass my suture lasso into the substance of the distal stump of the Achilles rupture and pass it into my surgical site. Now I pass my medial stump medially, lateral stump laterally. Also, as you can see in the very bottom right, the step 4, this is how I typically used to put my anchors, which is more perpendicular to the long axis of the Achilles. But I was having some issues with these anchors pulling out and causing symptoms, specifically the medial one. And so I started placing the anchors more vertically. And this has really kind of gotten rid of that, because these anchors will have a little bit of pull out. And that's very bothersome when people have this huge surgery and they're like, why is this hurting? And so once you start putting the vertical placement, even if it's a little pull out, it doesn't cause any symptoms. So what is functional rehab? This is what I mean. At 3 months, this patient had his Achilles repaired using the mid-substance PAR system. He is fully back. I mean, look at the video. He's walking. He has no pain. I mean, he can't go back and to run a marathon, but after this video, I cleared him fully. And he actually went to Colorado and did a very aggressive mountain biking trip and had no problems. As you can see in the picture, when he's going up on his tippy toes, the nice contour of the gastrocnemius complex is visible, and he is doing great. So, so when people have an Achilles rupture, we often tell people, hey, it's a year-long recovery. However, with this technique, I can pretty much assure people that you have a very good chance of 100% recovery. Now, I like to include this video because this age really mattered. Like, why am I repairing Achilles in an 86-year-old? Well, this 86-year-old ruptured his Achilles and he was neglected. I mean, he didn't have any treatment for about a month and a half. He came into my office walking with a limp and a walker, and he's like, look, is this as good as it gets? And I told him, if I don't treat your Achilles with surgery, it is going to heal elongated. You will have this. He's 86 years old, and he said, this is unacceptable. He's like, I know I'm old, but I'm healthy. I walk a lot. I don't want this. So we went ahead and repaired him in a delayed fashion. And look at him. This is at 3 months. And this is a quote from him. He said, this is my first surgery in 86 years, and I didn't expect such a fast recovery from what I've heard and read. He's ecstatic. He's back to walking 3 to 5 miles per week. Very happy patient. So improved functional outcomes regardless of age or patient goals. The key is this can get patients better, back to what they want to do. So let's move on to Achilles tendinosis with Haglund. Now, the highlights of this is that it's a faster recovery. There's less chance of wound complications because it is all done minimally invasive. It's less painful and improves aesthetics. Definitely help because this bump it's not unsightly, and we can completely get rid of it using a more minimally invasive approach. So why do I like the minimally invasive approach, and why did I convert my practice into that? Well, because you don't have to detach the Achilles. It's a faster recovery, it's less painful, and you can also debride the underlying calcification within the Achilles tendon, as well as the retrocalcaneal bursa. Now, is a speed bridge important? I believe it is. Why? Because we're opposing the Achilles post-debridement. And I think if you don't do this, then people can get a calcaneal gait causing heel pain. And that's intractable if you have a calcaneal gait. And post-op recovery is very similar. The first 2 weeks are non-weight bearing, and then we pretty much start the protocol. Start walking with an equine boot at 2 weeks. Every week, you basically take off a wedge. PT starts at 4 to 6 weeks. On average, this is a lot faster. Patients are actually able to return to all activities about 6 to 12 weeks. Now, this is a pretty interesting gentleman. He's a 77-year-old who had a MIS Haglund resected with speed bridge repair, and I shortened his Achilles by 2 centimeters. Why? Because he had a neglected Achilles rupture that actually healed elongated. So I treated his Achilles rupture about 3 months out. And at 7 weeks, he was 100%. I mean, his goals weren't like to run a marathon. His goal was to walk with my wife. He lives in an RV, to actually traverse stairs without a limp and just enjoy life. And at 7 weeks, he's like, this is perfect. This is exactly what I wanted. So this is a picture of that gentleman pre-op. At 2 weeks, you can see the incisions. One was for the shortening of the Achilles. Now, it was a slightly larger incision because I had to do a little tenolysis because he had scarred down from a rupture that was neglected. And you can see the incisions more on his calcaneus. So there are 6 incisions wide. The top 2 are where I reattached his Achilles using the mid-substance repair kit. The bottom 4 are where I did the speed bridge repair. And the medial and lateral incisions are where we did the debridement for the Haglunds. And this is him 7 weeks out. You can see the nice contour. I put Fortunato there because he's a patient of mine who kind of convinced me that the MIS is the way to go. So to just give you a brief synopsis of his story, I met this patient, and this is a different patient, by the way. He came to me for a second opinion. So he had the traditional Haglund resection with the French door incision, which is opening it up. He also had an FHL tendon transfer. He had wound complications, so we basically guided him through that, let him heal. It took him over a year and a half to recover. He had the same issue on the other side. And he said, there's no way I would ever commit to such a surgery ever again in my life. Eventually, he decided, I want to try the MIS. So we did the MIS procedure, which is the exact procedure, the MIS Haglund resection with speed bridge repair. And true story, he was able to walk pretty comfortably about a month out. He was back to riding his bike at 6 weeks. At 3 months, he had 100% recovery and he was back to running. And I share his story because I think it's a powerful story of how MIS can make such drastic impact. I mean, I don't know any patient out there that would take a year and a half recovery versus a 3-month recovery. I think it's a game changer. So talking about the MIS Haglund resection technique, obviously it's a prone positioning. I ensure you can visualize with a fluoroscan. Lateral imaging is very important. I also use 0.062 K-wires times 2, and these are placed percutaneously. And this is your guide for the resection of the Haglund deformity. I also mark the superior inferior borders to mark the center position where I'm going to basically be putting in my burr. So as you see on the step 2 picture, I picked the center point and I'll make a stab incision both medial and laterally, and that's what I'll introduce my Shannon burr. When I introduce the Shannon burr, then I'll just go ahead and start burring the exostosis down. I'll alternate this with a 4.0 arthroscope to debride it. And as you can see in the step 3 picture, you can see the K-wire. So I basically debride down to the K-wires. Now there are some little metal fragments that could shrapnel off, and that can be easily removed with the arthroscope. And then after that, the final step is to oscillate, using oscillating ramps to get that smooth surface. And then finally, we put the speed bridge on top. This is a more bird's eye view. So you can see on the picture on the left, you can see the K-wires. On the right, you see me with the arthroscope, basically cleaning it out. And then on the bottom right, you can see me introducing the burr. I'm using my non-dominant hand to basically guide and push the exostosis to the burr. And the K-wires prevent you from digging into the native calcaneus further. And also, I think a key point is people say, well, what is the MIS burr? Why is that important? The MIS burr is important. Why? Because it is a low speed, high torque system. And when I use my MIS burr setting, I mean, everyone will find what works for them, but I put mine at 6,000 RPM. So this is just another case. It's a 68-year-old female who had a painful Haglund deformity with insertional calcific Achilles tendinosis. So she underwent debridement with the MIS burr. She had the speed bridge repair. We also did BMAC and PRP. And at 3 months, she was pretty much back to all activities. And again, this is about getting patients back to living their lives functionally without pain. So I just wanted to finish up on biologics. So biologics have made a huge difference in my practice. Now, I often use PRP, BMAC, and amnion for Achilles surgical procedures. On the picture, the Angel system is for the bone marrow aspirate. You can actually use this system. So when I use that and put my iliac crest bone marrow aspirate, I'll actually run it a second time and have my anesthesiologist pull peripheral blood for PRP. Now, if you can't do this in the OR setting, you can also do just a PRP, which is that video on the right. That's just me in clinic, just getting peripheral blood and using platelet-rich plasma. I feel like biologics are low risk, but a very high reward, and it does make a difference. And science is out there to back it. So ultimately, what is their goals of care? The goals of care is 100% recovery is the ultimate goal to care for the patient and provider. I think using biologics with advanced technique and implants is key. So biologics in this case is amnion, PRP, BMAC, and advanced techniques such as MIS burr, mid-substance, and speed bridge repair kit. Now, I think whenever you're approaching this, you have to discuss surgical and non-surgical care for ruptures, as well as trial of non-operative care for Achilles tendinosis. Now, my suggestions for people watching this video is that there is a learning curve associated with the MIS technique. One of the easiest things you can do to acclimate to using the burr is use it for open procedures, such as fusion. So in this case, this is me fusing a first MTP. And this is actually how I really learned to use the MIS burr. I would just basically use in an open setting, use the MIS burr to remove the cartilage from the metatarsal head. So it's a gradual learning process. The learning curve is steep, but once you get acclimated, it can make a huge difference to your practice and improve functional outcomes for patients. So that's my talk. And if I have any questions, I'm happy to entertain them at any time.
Thank you, Paul, for that very short and sweet talk, but carrying very important messages. Couple of questions from our side, Paul. Now, there's a paper, I was just going through the quality of evidence, and there's a paper that was published in AJSM 2015 by Thomas Clanton. And he looked at percutaneous versus open repairs of the Achilles tendon. And there's a concern about early elongation with MIS. And if that is a concern, do you think there's a difference between your postoperative management between early versus, percutaneous versus open methods?
Yeah, I think that can happen anytime with elongation, regardless of MIS or open. I think the key is when you're doing the MIS, you have to actually cycle and tension the Achilles to make sure that the foot is in more equinus. And I will actually put it a little bit more tighter than I would typically do because it will stretch out a little bit. But I think it can happen regardless of open or MIS. I mean, I would say in my practice, I haven't had that happen, but I think it is a little bit of that technique where you have to tension the Achilles. So once you pass the proximal sutures to the distal stump, you actually take those sutures and you cycle it to bring that foot back into a plantar flex. And then I also gauge it when you put it in. You put both ankles you bend both knees to see the equinus positioning of both feet. And when I'm putting it in, typically it's like this, but I'll make it just a touch tighter, not like this, just a touch tighter. And that tends to work out well.
Thank you, Paul, for that. And you've mentioned different biologics. For example, you mentioned about amnion, you mentioned about PRP, BMAC. Now, what are the indications where you're going to use a BMAC? Because that is going to be a slightly more aggressive strategy, isn't it?
Yeah, so BMAC I'll use intraoperatively. I'll never use that in clinic because to take bone marrow from the iliac crest is quite a painful procedure. And I like the idea of combining BMAC, which is more progenitor cells, and PRP, which is more growth factors. So I think that combination just makes sense to me. But in a clinic setting, I'll just use PRP. And I use it for everything. I mean, I use it mostly for tendinopathy, tendinitis. I've actually even used it for arthritis, which to be honest, doesn't work quite as well, but it buys people time.
So technically, are you able to combine PRP with BMAC? Is that what you mentioned?
Yeah, so with the Angel system, you actually run the cycle and get a syringe of BMAC. You run the cycle again, and then you get a syringe of PRP. And in the back table, I'll just mix it. Because typically what I used to do in the past is I would inject them separately, but I'm still injecting them in the same site. So my thought was, why not just combine it? And I actually talked to some of the product managers at Arthrex, and they said that's exactly what we would recommend too.
Thank you, Paul, for that. And just one last question before we wind up the session. Now, there's a lot of interest with this amnion membrane, right? So in the shoulder, in the foot and ankle, what is the quality of evidence? Do you think the evidence is in par or is it superior?
So the main reason I use amnion, people say growth factors and all this, but the main reason I use it is because amnion has both a dermal and epithelial surface. And so we know that regardless of what kind of surgery you do, you're going to scar. And so when I do this repair, after I do the mid-substance, for instance, for Achilles rupture, you can actually sometimes visually see this, the fiber tape. And I think that's going to be an irritant. And so what I like to do is I'll actually reinforce it with ovicral suture. And I'll put the amnion dermal side down, epithelial side up, and I'll just wrap it like a little burrito, and I'll tack it down with forovicral. Now, at first, I was like, I'm not even sure if this is doing anything. But I would say maybe 2 years ago, I had to go back because I did this also I do it for pretty much all my tendon surgery. So I did it for a perineal surgery. And I went back and I'm not sure, I think he needed a brostrum, and I was able to actually visualize through a small window his perineal repair. It looked absolutely normal. Like normal. Like I couldn't even tell I did surgery. I couldn't see any of the sutures I did to repair it. And I was like, that's when it was mind blowing for me. I was like, this had completely incorporated. And that's why I don't like I know some people like to use those dermal graft tissues, which are thicker for Achilles. I don't like that because I don't think it's going to completely incorporate. The amnion I use is almost like thin tissue paper. It almost like melts. And so yes, growth factors are important, but I use it more for scar prevention because of the dermal and epithelial surface.
Thank you, Paul. I think that's all the questions that we have for this session. Thank you for yet another fantastic lecture, and I'm sure this is going to benefit a lot of people all over the world. Thank you so much for joining.
Thank you very much. Thank you for having me.
Goodbye.
Bye.